and then I will allow the lovely ladies to, provide more background information on their credentials. How about that? Sounds good? All righty.
Alrighty. It is setting it up right now. We're good in 5, 4, 3, 2, 1. You're all good.
All right. Good evening, everyone, and thank you so much for attending our next installment of the Gaston County DHHS Health Equity Team Town Hall Series. My name is Krystle White. I am the Manager of Health Equity Outcomes and Manager of the Health Equity Team here in Gaston County. So we have a really special event for you this evening. Of course, we have two of our lovely superstars within our county. Two of our most reputable and respected and loved physicians that are truly out, boots on the ground in the field every single day, really understanding what COVID is and all the science behind it. And so when we, of course, wanted to start this COVID series, we wanted to make sure we had the most up-to-date information that we provided to you guys, so that you can make an informed decision on whatever it is that you want to do as far as COVID is concerned. So we want to make sure you're safe and that you have everything as far as the tools and resources needed. So without further ado, I wanted to go ahead and introduce our panelists. So tonight we have Dr. Tia Robertson, who is the Medical Director for the Gaston County Public Health. Public health, we should say it like that, but she resides at our health department along with me in the health equity team as well. And I will let Dr. Robertson go ahead and provide some background information for herself before we go on to Dr. Bowe.
Good evening, everyone. It's a pleasure to be here. I'm an obstetrician and gynecologist by training, board certified, and I've been working with the Gaston County Department of Health and Human Services since March of 2018, and it's been such a pleasure to serve in this capacity.
Awesome. Thank you so much, Dr. Robertson, for being here this evening. And last but not least, we have the amazing Dr. Crystal Bowe, who is with Caramont Health, and I will allow her to do the same and provide a little bit of background information as well.
Hi, my name is Crystal Bowe. I'm a family medicine physician with Caramont Health, and I also serve as their primary care service line medical director. I've been in Gaston County for 8 years. I am the mother of 2 children, one of them a South Point graduate, and I'm a North Carolina native, so I'm happy to be here with you guys.
Awesome. Thank you so much. All righty, so let's get right into some of the questions. So I went ahead and sent the majority of the questions that we received early on to our panelists so they can kind of get an idea of what we're going to be talking about today. For the most part, I'll let you guys know before we get started, we'll be going over some of the most recent trends of dealing with COVID. So when we're talking about boosters, when we're talking about whether or not the booster and the third shot is something different, some of the new CDC guidance and all of that. So all of those burning questions that a lot of you guys have had within the community for the past few months, we want to go ahead and get all of that done to this evening. All right, so one of the very first questions that a few people actually submitted is they wanted to actually have you guys explain how a true virus works and what does it actually mean when you say that it mutates, because of course now with the Delta variant and several other variants that are now kind of popping up around the world, a lot of people are really unsure of how we've gotten here. Like, how did it start off here and now we've gotten a whole nother variant that we're apparently dealing with at a much faster rate as far as infection and everything like that. So I will leave that open to either of you guys to kind of maybe just give a little bit of background information for the community.
I am happy to do that because I also taught biology in North Carolina. So everybody heard this back in 10th grade and no one remembers it. I'm not judging. So when we talk about viruses are live organisms, but only RNA. And the way that they thrive is by infecting other things and replicating in cells of other animals. That's basically what viruses do. There's a whole lot of them. There's some that you've known of forever. There's the flu, there's streptobacteria, so that's why that one's different. But when you think about the flu, you remember every year the flu comes back bigger and better and it changes. Viruses are made up of RNA. RNA is single-stranded. It's easy to change. And this is what makes viruses successful. They're simple, but very adaptable. And like with anything else, the more you let it replicate, so the more viruses that is made, the more that virus can change. You can change out 1 or 2 parts of that genetic code. So that's what happens normally. Now, this is important because coronavirus is not new. We've had coronavirus forever. Both of us learned about coronavirus in med school. It was one of the most common causes of the cold. For some reason, there was a mutation, a change in the code of the coronavirus, and this virus has become like the LeBron James of all viruses. I mean, it's everywhere. It is unstoppable, and it is spreading so fast that the more it spreads, the more it can change. And the way this works is when it spreads and changes, only the good survive. So the better the spread, the more infectious, the more, not too deadly, because they want it to be able to spread first, but the more it spreads, the better it gets. What happened was we started with the regular coronavirus. It was doing pretty well, this new COVID-19 variant. And out of these changes, because there were so many sick people for it to replicate in, we got the Delta variant. There have been other variants. There's Alpha, Beta, but Delta's taken over. I mean, it is really good at what it does. It spreads faster. It's harder to detect. It's more like a sinus infection. And so this virus is going crazy. The more the virus can mutate, the more bodies it can get into, the more it's going to change. So when you talk about variants, Delta's not the last variant. It's the best variant, meaning it's been spreading the most so far, but there's others coming. There's Mu, there are things to worry about coming down the pike. So I hope that explains a little bit about viruses and why they're so good and terrible.
Yes, and Dr. Bowe just gave an excellent explanation. And, I also like to add to that, when those viruses change, when they switch out the genetic code, sometimes what it is for the coronavirus, they're switching out the code for the spike protein on the coronavirus. So that's what makes that Delta virus so special. So when you think about the coronavirus, think about a sphere or a ball, and then all these spikes all around it. And then the spikes are what attaches to your normal cell. Dr. Bowe's she's gonna draw a picture because she's like me, we're visual, we're gonna draw a picture. So she's gonna draw a picture of this coronavirus. There you go.
This is the virus where the RNA lives. This is and guys, I'm not an artist. This is the spike out here that attaches to the cells and gets in and makes you sick. That's it.
And I think we have a few more questions later on where we're going to use that drawing again to help explain what happens when we use a vaccine and how the vaccines are effective. But what happens is when that genetic code changes on that spike protein and makes it much easier for it to attach to the cells, it becomes easier to get inside the cell and use the cell's resources to replicate. And that's how you become infected, as Dr. Bowe mentioned earlier. So the concept of mutation may sound abstract, but really it's just changing the genetic code, and it's like an error. When you replicate something so many times, at some point in time, you're going to have an error. And sometimes those errors are not very effective, and the virus gets weaker. But sometimes the errors are like jackpot, comes to LeBron James, and it just proliferates everywhere. And that's what's happened with the Delta variant.
Wow, thank you both so much. I mean, obviously, I'm, engrossed in all of this all the time, but just hearing that breakdown even more so helps me to understand how everything kind of works out when it comes down to this particular variant and how this is kind of working out. Because of course, like Dr. Bowe said, we did get it in 10th grade, but a lot of those key messaging points that you guys brought up, I feel like a lot of us probably forgot. So it's good to just really understand exactly how we've gotten here, because I do feel like the majority of the questions we've gotten, it's like, is this a made up situation? Are they kind of overblowing the fact that this variant is present? And this helps us to understand that, no, this is how a virus works, and this is why we're here. So,
and I'll say, so we know viruses are real because everybody knows about the flu, everybody knows about colds. We all know about different viruses. This one is not overblown, but we only get a pandemic about once a century. We haven't had this many sick people at the same time in 100 years. So for most of us, I do have a couple of patients who get this, we've never seen this before. So it is hard to understand. You're like, this many people can't be this sick, but it's true. And if you look at newspapers from 100 years ago, we were saying the same thing back then when we had the flu pandemic back in 1918, 1919.
Right. Awesome. Well, thank you for, again, reminding the audience of that this is something that has always been around. All right. So one thing we've been hearing about that there's a difference in the symptoms of this particular variant and the initial coronavirus that we were introduced to in 2020. Could either of you please speak to what those symptoms are so then at least the audience is aware of, you know, if there are any additional symptoms outside of what they might have been aware of, like with the runny nose, maybe the sore throat, the coughing, if there's anything more than that. I know, Dr. Bowe, you said it kind of resembles a little bit more symptoms there. So could you guys speak to that?
I'd love to, because I've been seeing a lot of this. So our original coronavirus, you had cold symptoms. It seemed like the flu, but then you were having stomach symptoms. You were having diarrhea, a really bad headache, and you lost your taste or smell. And everybody knew if you said you lost your taste or smell, we were worried. In August, we started having the Delta. And the Delta is terrible because you don't always lose your taste or smell. You don't always have the stomach issues. For many of the patients I've been diagnosing, they're like, it's just my allergies. I just have a sinus infection and a headache. It's literally a sinus infection and allergy symptoms during allergy season. And so many people who think, this is just my regular sinuses and I'm just having a headache with it. They have a little bit of fever. You test them, that's coronavirus.
And I like to add too, because we're in a state now where the infection rate and the community spread for the Delta variant is so high, we need to test everyone for coronavirus. If you think you have your normal allergies or your normal symptoms for a sinus infection, still get tested anyway, because we have such a high transmission and it's really difficult to figure out which one you have, coronavirus or a sinus infection.
And so sinus infections are caused by viruses every year, regular viruses. This year, many of the sinus infections are caused by the LeBron James of viruses this year. And so where people are like, I get a sinus infection every year. Yeah, you do, but it's not because of this virus.
That's really great to know so that people can know the difference in that. And it's true how ironic we're kind of going into, again, allergy season. So I can see most people thinking, well, no, this is something I deal with annually. This isn't something new. So why would I even need to get tested? But to Dr. Robertson's point, I think we all have to do our due diligence. And if we do feel any of these symptoms, just go ahead and get tested so we know that we're safe. So thank you so much for that. All right, so next, this is a really important topic, or should I say question, that'll lead to a further discussion with the topic, but we're wanting to know what is the current state of our hospital capacity in our region right now. And you kind of touched on this with the variant, but the question was what has attributed to the increase in COVID numbers lately? Obviously, we know the variant is a key point there, but more so, speak to me about, or the audience about, how the variant and the contagious rate and all of that has now caused what people are not people, but our medical professionals are saying, a real strain on our hospital system yet again, because we know we were introduced to a lot of this early on in March and April of 2020, kind of leading into there, but now it seems like we're entering right back into that same space. So could you guys really help the audience to understand what's kind of going on in our hospital system right now?
So I can talk about what's happening not only in our hospital system, but in all hospital systems in the area. In July, we were around, I think we were below 10% in the community. So less than 10% of people in our community, I think we had gotten below 5% at one point, had COVID. We had very few people in the hospital with COVID, very few. We didn't need all our COVID wards anymore. We were calming down. By August, our positivity rate was up to 18%, and we were up to capacity daily. So in our region, that's all 3 hospital systems, We are all running out of beds daily. We are all having an increased number of hospitalized patients from COVID daily. Instead of having our small COVID section and then the rest of the hospital zone, we're having COVID floors again. And we had gotten away from that. Every hospital in the region is suffering. And you can see stories like this around the country where people are sick and they can't find a hospital for 3 hours that can take them. We are now drowning in patients, and we're at a critical point because not only are we trying to take care of all the COVID patients who are sicker, ventilated, they stay in the hospital longer, we still need to try and make room for heart attacks, car accidents. Don't break your leg right now. How will you get in? We are drowning. And so the problem is with so many sick COVID patients, we don't, and this is all over, have the capacity for the regular sick people who are coming. And the risk with this is we haven't even gotten to our regular cold and flu season. So we're still on that upward climb from other medical problems coming into the hospital, which is why we really want people to do the best they can to protect themselves against COVID.
And I'd just like to echo all of the sentiments Dr. Bowe just stated so eloquently and add, again, people who would normally be seen for their critical conditions like heart attack, stroke, or they need to be monitored in the hospital because they're having some sort of problem with their heart or their lungs. These people aren't able to get the access that they've had before because there just isn't enough availability, accessibility. There aren't enough resources. There aren't enough staff to staff the hospital beds to adequately take care of people. And again, this is going on all over the country. You know, you have good community physicians who are trying to advocate for their patients and get them inpatient, admitted because they need to be monitored for some reason. They have to call 4 or 5 different hospitals in the region just to get them a bed somewhere because there isn't anything available. So that's what we mean by our hospital systems being overloaded. It's not just with COVID. I have to think twice about my activities because I don't want to get hurt. I may not be able to get inside to a hospital to be taken care of appropriately, right? And we don't need to be at that state. You know, we're a powerful country. We should be able to be in a place where we're well suited to take care of the population that needs us. And right now we are drowning, and it's a state that we don't need to be in right now. We just, it's got to change. Something has got to give.
I absolutely agree. This particular question is a very sensitive topic for myself, only because I've known family members and close friends that have had loved ones that had some of those pre-existing conditions and couldn't get into the hospital system and unfortunately passed. And so hearing those type of scenarios where they literally were just someone might have had a heart attack and were not able to actually get in when they were, needed to actually see a doctor as a result. And because of that delay, they end up passing away. So it is something that I think the audience should absolutely understand and know that it's not just something you're seeing on TV and thinking it's a hot button topic. It's really happening to real people in our community. So thank you so much for both of you for answering that. So our next question says, we were recently made aware that the Pfizer vaccine currently has FDA approval for a booster shot. What is the current development phase for the Johnson & Johnson and Moderna booster vaccine, if you know of one? And then the second part of that would be, if the vaccine is working, why is there even a need for a booster shot? A lot of people have had questions about that. They're like, well, I did what I was supposed to do. I got my 2 shots or my 1 shot, my J&J. But now you're saying all these months later, I need to get a booster. Is that speaking to the efficacy rate of how they're, actually performing in our bodies? Could you guys speak to that? Either one of you.
I'm going to talk to why we need boosters first. And then I'm going to let Dr. Robertson talk about these vaccines coming out. So I've heard a lot about, well, if the vaccine works, why do we need a booster? I understand that. The purpose of a vaccine is to create antibodies in your body. So your body gets a shot of what it thinks is the real deal. Your body sees this stuff and says, oh, we got to create antibodies. And your antibodies are like your community watch. So your body makes a community watch, but there wasn't really a burglar. So when the real burglar or the real virus shows up, the community watch like, we know him, get him. And you have that response. Now, over time, these antibodies don't live forever. If you have immunocompromised states or you're on medicines that suppress your immune system over time, the community watch wanes off. You don't have as many out there, which means a virus, particularly one that's mutated some, can get in and make you sick. So the reason for the booster is we know the vaccine is working. We know 99.2% of people dying from COVID are unvaccinated. However, we want to keep it that way. So we're going to remind everybody, put up flyers. Hey, there could still be a burglar. Get some more antibodies out there to keep folks protected. This is particularly true for folks who might have weaker immune systems. That's why we were doing this for cancer patients first, immunosuppressed patients first, now elderly. We were looking for folks whose immune systems aren't as strong as it used to be to help protect them.
And currently, Johnson & Johnson and Moderna are both working on booster shots for their individual drugs. And of course, they both will need to go through the FDA approval. So we're still waiting.
The last thing I'll add with boosters, we've had boosters on other vaccines, guys. We all know that we have to get boosters. We know that nothing lasts forever. Any patient who's seen me knows, when was your last tetanus booster? That lasts about 10 years. Why? Because antibodies don't last forever. So I don't want you to associate needing a booster with just the COVID vaccine. You get boosters all the time on other vaccines. This is just the vaccine that we're doing the booster for today.
Amazing point. Amazing point, because I do think that reminder of the fact that we've had boosters throughout our lives. So this isn't the first time we've introduced this idea. So I'm so glad that you brought that up, Dr. Bowe. Thank you so much. And Dr. Robertson for the update as well. All right, so another question, kind of speaking to this or the efficacious ness of the actual vaccine. They're wanting to know, so if it is so effective and so great, why is there a need for universal masking? Why is that still encouraged? Could either of you speak to that?
Yes, let's talk about it.
Talk about it together. We like this topic.
You know it. Okay, so yes, the vaccine is very efficacious. However, many of us in Gaston County are not yet vaccinated. I try to tell patients, the vaccine protects me, the mask protects you. When we're not at herd immunity yet, we're trying to save the whole community, the vaccinated and the unvaccinated. The mask is to protect all of us so that we don't have these huge spreads. The masks work to prevent spread. The vaccine works to protect you and keep you from dying from COVID.
Absolutely. And the other thing that we know is that you can be asymptomatic and still spread COVID. So if you're wearing a mask and you're asymptomatic, you're not going to spread that virus to someone else because you don't feel sick. And that's another really important point to realize, that you don't wear the mask just because you're sick. You wear it because it's a preventive measure, and we have to layer our prevention, our mitigation efforts. So you wear your mask, you still socially distance 6 feet apart when you can, and you still follow the hand hygiene.
The last thing I'll add to that, every life matters in Gaston County. Every life matters in North Carolina. If me wearing a mask, socially distancing, saves one life, one child, one grandparent, one of the church members of the church I attend, it's worth it. So I understand people saying, well, why do I have to do this? Why not? If it can save someone you know, someone you love, someone you don't know, why would we not do that? If we consider all life precious, let's act like it.
I love it. I love it. And one thing I love to say is, if you can't do it for yourself, or you don't want to do it for yourself because of your own personal reasons, do it for someone else you love.
Absolutely. I think one thing I've recently spoke to a few colleagues about is that, this is something where we have to look outside of our own selfishness, right? And we have to put that to the side and look at the community as a whole, and know that if you're doing your part by masking, getting the vaccine, that you're making a selfless action on behalf of the community. So I thank you for bringing that up too, both of you. Thank you. So another question we have is, can you speak to the potential long-term effects of the vaccine? This is what we've heard, the misinformation about, you know, some of the things you've heard in the news recently and pop culture, impotence and infertility and all that other stuff, right? So I wanted you guys to kind of just lightly touch on that. But then also, I would love for you guys to also speak to some of the potential long-term effects of someone who's diagnosed with COVID, because I know a lot of times it's one-sided with this argument, right? We like to talk about all the side effects with the vaccine, but yet we're totally avoiding that there are potential side effects with having COVID. So could maybe one speak to one and one speak to the other?
Sure, I'll speak to the vaccine and I'll have Dr. Bowe speak to the long haulers, as we call them. So there are no long-term effects from getting the vaccine, okay? You will have some side effects that'll last you for a couple of days, 24 to 48 hours, maybe a little longer than that, nothing more than that. You may have some itching or some swelling or discomfort in your arm where the injection was. If you have maybe a little low-grade fever or body aches, chills, after the first 24 hours, those symptoms or those issues typically self-resolve. And if they don't, you can take some Tylenol or Advil and you'll be better and you can get on with your regular life. And that's pretty much it with the vaccine. Long haulers, completely different story. And I'll have Dr. Bowe inform you about what happens with the long haulers.
So a lot of people talk about their fears around the vaccine. The first thing I'm going to say is there's no chip. I don't even know what to do with that, but I can only talk about the science. So we're going to move past that. There's not the concern for infertility. And some of the data that I would use for that was within the Pfizer trial, the women that they were watching, some of them got pregnant. So, well, they got pregnant. So I think we're okay. And I've had many patients get pregnant during this COVID time period post-vaccine. So we know COVID babies are being made. Effects of COVID are wide ranging and they can be devastating. There's the effect we talk about most, which is death. That's happening regularly. We know that of people who get COVID, 40% of them have at least one symptom 9 months after having COVID. There's a significant increased risk of blood clots. So much so that once you've been hospitalized with COVID, we're putting you on a blood thinner because we know those blood clots can happen. Because there's an increased risk of blood clots, that means there's increased risk of pulmonary embolisms, DVT, strokes, those things happen. There's an increased risk of heart problems, myocarditis. There's an increased risk of depression, insomnia. Some patients have had delirium afterwards and been hospitalized for that. Commonly, people note a chronic shortness of breath, fatigue, body aches like they've never felt. They develop like fibromyalgia and it just won't go away. So I've got patients who are almost a year out who are still suffering. They're better than they were. So they're off their oxygen because people leave the hospital on oxygen, but they can't run a mile where they used to run several miles. They have headaches. They can't sleep. They're depressed where they were never depressed before. Those things are real and they're common. And so when people talk about mild COVID, by the numbers, mild COVID is you didn't go to the hospital. That doesn't mean it's mild for the person suffering with it. These people's lives are different and they're worse because of COVID. And my fear is that we're going to be dealing with these long haulers for a generation.
And I'd like to also add, I believe that several people are concerned about the VAERS numbers. I think there's some information out there about the side effects that are reported if someone's gotten the COVID vaccine. And that number, I think, is around 6,000 or something like that, right? So what that reporting system is, it's just a way for us to follow up with anything if someone has any kind of response to the vaccine. It doesn't necessarily mean that those two are related. So, but it's a report to say, hey, someone developed hives or something like that, and they did receive the vaccine. Well, we want to know about that. This is a great system. Please report all of it. Nurses, physicians, the general public. We want to hear about everything that you feel is related or happened after you received the vaccine. At this point, most of those claims are not related to the actual vaccine administration, okay? Now, J&J did have a few adverse events where 1 in a million essentially develop blood clots. This was a subpopulation of women less than 40 years old. And there were a couple of deaths that were related to that. But outside of that, we have not had anything that's significant enough to say that the vaccines are ineffective or unsafe. And that's the most important thing. We've given over 300 million injections with so few severe reactions or adverse reactions. This is still considered a safe vaccine for the purpose of getting us through this pandemic.
One thing I'll add, for anything you're worried about with the vaccine, like blood clots, the risk is much higher with COVID. It's much more common with COVID. I've seen no blood clots because of the vaccine. I've seen a dozen blood clots because of COVID, and I'm one doctor in Gaston County.
I'm actually kind of glad you brought that up as well, because I have not heard that was a common long hauler type of scenario. I've only heard that with the vaccine. So I think, again, it speaks to the misinformation of the fact of everyone thinking, well, if I get the vaccine, then I'm gonna get a blood clot. Dr. Robertson just said it's a 1 in a million chance. But then you hear Dr. Bowe saying, hey, if you get COVID, there's an even greater chance for you to get actual blood clot. So again, I think it's something to think and consider.
And to be clear, that risk of blood clot is highest in the 30 days or 90 days after COVID, but it's still a real risk. It's happening.
Wow. Very interesting. Very interesting. All right. So another question we have is, someone wanted to know, is there an actual difference between a booster shot and a third shot? Is it the same thing, or is it something totally different?
Yeah, I understand that question because people use the terminology in different ways, and it hasn't really necessarily been consistent when it's reported out in the media. I can tell you the way that the CDC reports it is that if you get a third shots are essentially for people who are immunocompromised. So meaning that if you're immunocompromised, then your body does not, what did Dr. Bowe call it? Your community watch, they're not as active when the virus presents itself, right? So it needs the immune system needs a little bit more help. And so there's a third shot to escalate the immune system to the level of someone who is not immunocompromised, who has a normal immune system. So that's called a third shot. That's just getting you up to a normal state of response for your immune system. The booster is actually, per the CDC definition, the booster is for people whose immune system was appropriate and they did have the appropriate response to the initial vaccine, but over time, the protection started to wane. And so that's why you need the booster. And that's the difference.
Got you. Makes sense. So a follow-up question to that would be, if I were to initially get a Pfizer vaccine, should I get a Pfizer booster? Or is it okay for me to get a Moderna or a J&J? That's another question I've had asked.
So per the current guidelines, you stick to the one you had. If you had Pfizer, I had Pfizer, I'll get a Pfizer booster. If you had Moderna, you would continue with that. If and when they give the booster for Johnson & Johnson, you would do that. There is no indication yet that you can switch between.
Good to know. Good to know. Awesome. All right. So let's see. Now I'm going to go through a series of myths, or we'll deem it myths or facts. So I want you guys to speak to these statements and tell me whether or not you believe it's a myth, or if it's, not believe, whether it is a myth or if it is a true fact. So the first one we have listed is, none of the COVID vaccines went through clinical trials. So is that a myth or is that a fact?
That's a myth.
A myth.
In fact, the Pfizer vaccine, I believe, was the largest vaccine trial they had ever done. They included 70,000 people. 12% of this population was African-American, which means it was representative of minority communities, which is often unheard of in trials. Myth, myth, myth.
And also realize that the FDA only gave the EUA to 3 drugs, and now the Pfizer has the full approval. But there were other drugs in the game. There were other companies trying to get a vaccine that they weren't approved. So just know that there was a selection process.
Yeah, there is this idea that all of them got through. There were like 25 and only these 3 got through. There's
Right.
one that's offered in other countries that we're like, nah, we're good here. So we're pretty picky. Just
We're
know that.
selective.
Which means it had to go through some type of trial and error process for us to determine that. So good.
I'll
thank
also
you.
add for the Pfizer vaccine, that research started in 1990. So they've been researching it for quite some time. It wasn't new. It wasn't like, oh, we're just going to make a vaccine. No, this research had been going on for decades. So they had a lot of science to use for them to have the trials. And then they actually did the real trials. And they did get real FDA approval. I'm just going to jump to that. Yes, this drug has been actually FDA approved. I've heard, oh, it was a fake approval. Nah, it's real.
It's real. And I'm glad that you also brought up the fact that this research has been going on for some time now, because that was, of course, everyone's concern initially when we were hearing about the vaccine. Everybody's like, how could they do that in such quick time? And we were like, of course, those of us, on this end understand kind of the science that has been going on for so long for it. So
But the thing I'll add to that, so the research had been going on for decades because like we just said, coronavirus isn't new. The LeBron James of coronaviruses is new, but the virus had been around. And I don't know if you guys had ever heard, years ago, they were saying they were going to make a cure for the common cold. Well, this was that. They were working on it. They have been working on it for quite some time. So scientists are always working on weird things that no one is interested in until we're interested. And this was one of those things. There are researchers who have dedicated their whole career to mRNA vaccines. It's not new.
And I'd also like to add that once a drug goes through the clinical trial process, there's a post-implementation monitoring that happens as well. So once, like the Pfizer vaccine that's already approved, is now being monitored now after being approved by so many different committees. So the scrutinizing of this drug to make sure it's still safe and it's prepared and manufactured appropriately and all those things are still being followed. And that's the benefit of our FDA approval process, is that once it gets approved, it doesn't just stop there, it continues. So we're under good care with the monitoring of this FDA approved drug and the ones that are still pending.
that is great. Awesome. All right, next, so we have another scenario. So most people who have died from COVID-19 would have died soon anyway. Is this a myth or a fact?
Now, I'm going to speak to that across the spectrum. I have had patients 50 years and older who have died from COVID-19. The idea is if you have any comorbidities that you were going to die anyway. Let me tell you what these comorbidities are: being obese. And y'all, we are in the South. I want folks to think about, oh, these folks are going to die anyway. Are you diabetic? Do you have high blood pressure? Do you have some weight to lose? Well, if you die from COVID, they're going to say it was your time anyway. No, these people were living, they were engaged, they were active in their communities. Right now, we're seeing people in their 30s and 40s with no medical problems. We're having children actually be orphaned due to COVID-19. This virus will go after sick people, but it goes after healthy people too. And what really annoys me about this is my patients in their 60s or 70s, you're not supposed to die in retirement. These people are living long, productive lives. We don't value life less at 70 or at 80. And so this idea of, well, they were gonna go, no, they weren't. They had another year, 10 years, and all that time mattered to their grandchildren, to their friends, to their family members. It's a devaluing of life, I hear, when we make those statements. And there are very few of us that can say we don't have any comorbidities, that we're good to get COVID.
Right. Well, good. I'm so glad that you were able to kind of explain that, because I have heard that swirling around a lot too. All right.
I'm going to add real quick, Krystle. I think a lot of that thought, and I agree with Dr. Bowe, I think a lot of that thought has developed because in the beginning, we had a lot of deaths associated with long-term care facilities. We had a lot of hospitalizations that were associated with the elderly when the pandemic first started. But this Delta virus this Delta variant rather, is different. And that's why we were seeing younger people hospitalized and dying and orphaning their children, because this variant is not exclusive to the older population. It's attacking 40s, 50s, 30s children. And that's important for everyone to understand.
Absolutely. Absolutely. All right, next, another statement: the vaccine is actually causing these COVID mutations. You kind of talked about it a little bit in the beginning when we talked about how a virus mutates, but could you just kind of, I guess, speak a little?
That's actually the opposite of the truth. The vaccine can mutate the more it spreads. It spreads best in people who haven't been vaccinated. So the vaccine doesn't cause the mutation. There's no science behind that, so I can't give a sciencey answer. I could just say, when we stop people from being able to get the virus, thus likely to spread the virus, that means the virus has less chances to mutate. So the more people we get vaccinated, the less the virus can mutate and spread. That's why we keep talking about getting the vaccine, so we can get to what we're talking about as herd immunity. If we have enough people vaccinated, the virus is going to have nowhere to spread to, and it will drop down from pandemic levels, meaning it's a worldwide thing, to endemic levels, lower levels where everybody's not dying so rapidly.
And I also like to add that when we say vaccinated, we're meaning fully vaccinated. So if you got the mRNA, Pfizer, or the Moderna vaccine, just getting one shot doesn't mean that you're vaccinated, okay? You're just partially vaccinated. You need to get that second injection to be fully vaccinated. Otherwise, you're not going to get the full protection against the Delta variant.
That's a great point, Dr. Robertson. Thank you for putting that out there. So another statement is, it states, doctors and nurses in hospitals are recording nearly every type of death as COVID to drive the numbers up. Is this a myth or is this a fact?
That's a myth. As someone who has had to sign death certificates and write that my patient died of COVID, we don't do that lightly. And in the hospitals, they don't do that lightly either. The other issue is, if you write that someone has COVID when they die, it's harder to move the body. We wouldn't do things that make it harder for us to do our job. More importantly, there's no benefit to us in lying about why people died. Unfortunately, these people are dying from COVID. And this goes back to well, they had heart problems, they had diabetes. So how do you know that wasn't the cause? So they were walking around and living until they caught COVID, and then 3 days later they were dead. I mean, no, it's just not a thing.
Yeah, and I want to speak to that point too, Dr. Bowe. I've heard the conversations, well, you don't hear anything about people dying from heart attacks anymore, or strokes, or anything like that. Well, you know what? That's not the case. People are still dying from heart attacks and strokes. You may not be hearing about it because there's so many more people dying from COVID.
Well, and I will say, I have families who have lost patients to cancer, to heart attacks, to strokes. To them, it's devastating. And it's that kind of perspective of, well, if I didn't hear it, then it must not be happening. And that's just not true. Your perspective is not the whole perspective. Your knowledge and your view is not the whole view. You don't get to see everything that's happening. That's why we report on numbers and statistics. Even what I see is not the whole thing. I have to go and look at the numbers for what's happening countywide, and that matters.
Absolutely. Absolutely. All right. Well, thank you for going through the myth versus facts section. I thought this was really great. We have just a few more questions to ask you guys before we round out the entire event. So we know that, and Dr. Bowe, I know you can probably specifically speak to this because you've had to talk to our lovely county school board regarding universal masking within all of our public school systems. So could you both, or one or the other, speak to the importance of actually ensuring that our children follow this universal masking scenario, and that we don't just kind of leave it up to chance to say whether or not a child should or should not wear a mask when they're in school?
Yes. So first of all, I have never been prouder to live in Gaston County than these past 2 months with our school board. Our school board had originally said masks would be optional because the numbers looked good. We were at very low rates. We thought we were in a good space. Unfortunately, the numbers changed. We went into a surge with exponential change. And they made the hard choice to look at the science, to look at the numbers, to look at the safety of the teachers, the staffs, and the students of Gaston County. And they made the right choice and said, we need to keep the mask on. They need the mask on because not only does it protect the children, other children, the teachers and the staff, it allows children to stay in school more often, because unmasked children, when they are exposed, have to be out of school much longer. The quarantine is just bigger. So because of the choice that our school board courageously made, these kids are in school more. There's also data that shows if we compare Gaston County to Union County, Gaston County has higher community rates than Union County, but our students with COVID has been half of Union County's. That's because we're masking. The masking works and we have the numbers to prove it. So we don't want to play with that because you're risking exposure. You're risking your child being sent home for 2 weeks, everybody else's child being sent home for 2 weeks. And I don't know about you guys, but I like my child in school. She needs to go. So that's why we're doing this. It's for safety and it works. And because of what they've done, our kids are being educated and they're more healthy kids because of it.
Dr. Bowe couldn't have stated that any better. And now, I'd also like to add that if your kids are in school, that means that you can still go to work as well. So we have to work together on this. Masking works. It really works at every age.
Absolutely. Absolutely. I think one thing that my team was kind of nervous about early on with this pandemic, especially with knowing how the transmission rate was going and how the quarantine timeframes would be, some of the inequities that comes from that, right? So to both of you guys' point, when you're actually able to implement something like universal masking so that we can start to slow down and eliminate transmission, then we know we don't have so many children out quarantining for multiple days at a time. And I think a lot of times, something I used to have to always speak on in my previous position, if you actually live in the home with someone who was exposed to COVID, so if you're a parent and your child, you have COVID, you've been diagnosed, and now your child has been exposed to you and they can't really isolate in the home from you. A great example of this would be a single mother or father. How are they actually going to isolate in the home? You know what I mean? If you have a 3-year-old, you can't just say, hey, go over there and take care of yourself. You have to take care of that child. And unfortunately, even with COVID, that puts that parent in the predicament to still have to be around them. Now that quarantine time goes from 14 days to now 21. And I don't know about you, but I don't know of many jobs where or any individual that's really able to stay afloat, past 2 weeks, let alone 3, as far as financially being able to take care of their family. So it leads to an inequity when we're not thinking about how critical masking can kind of avoid something as simple as you'll be able to actually go to work. So I'm so glad you guys brought that up.
Absolutely. And I like to add masking for every age, meaning 2 and up. We don't want to mask our newborns.
Great point, Dr. Robertson. We don't want to have anyone having a mask on their infant.
Right. But we do want to protect them. We protect them by masking. If you are the appropriate age, then you should have a mask on.
Absolutely. And I also want to speak to the fact of what Dr. Bowe said about the children actually being in person this year, right? I've absolutely seen a difference in my daughter who, did not get a chance to actually go in person last year. And now that she's able to go in person, one of the fears a lot of parents have is the child going to be able to keep the mask on their mouth? Are they going to be, is it going to seem irritating to them? My daughter could care less about that mask because she is so excited about actually going into school and physically being there. So
I was going to say, one of the things I've seen with my daughter, she wears the mask every day. She's made friends. She laughs. She jokes. They are having a great time. They are doing well. She understands what her teacher says. Her teacher understands what she says. She is thrilled to be there, and she is thriving with the mask, much more than she did at home with her mean mother teacher. She did not like it. And now all my daughter says is, I can't wait for that vaccine because I want to get on a plane. And so I'm ready for the next step for our kids so that we can start having more fun again.
Absolutely. I totally understand. Truly. All right. So one of the very last questions that we have speaks to what is the actual availability of vaccines for our elementary school age children? I know that there's been some recent information that has come out into the news stating that ages 5 to 11 may be up next. So could you guys speak to that?
That's true. We're looking at ages 5 through 11 right now. And as soon as it's FDA approved, we'll be moving forward with that next group. So we're really excited, because again, it's extending the opportunity to protect those who don't know how to protect themselves, right? And we can give them the vaccine and it protects the entire family.
It'll get us closer to herd immunity. It will allow these kids to do sports and not have to quarantine. Our sports seasons have been, folks are having to be sent home, or you can't have that game because that team, there was an exposure, they had to be home. It's going to allow proms to be safe. It's going to allow kids to play and be together. This vaccine for all school age children is really going to help them with the return to normalcy and safety that we all want. And, these kids are they're really yearning for it.
That they are.
And the one thing I'll add is my child will be first in line. She asks about it every week. There are other children I know. So just so you know, you won't beat my daughter to this vaccine when it becomes available.
Well, that's good. I'm glad that she's at least excited because she knows, she understands the importance of it.
She likes the mutation. So, and I will say, in certain places in the country, you can't go without a vaccine. You can't travel out of the country and not quarantine, even if you're a child. You can't eat in certain restaurants if you don't have a vaccine. And it makes sense. They want to keep people safe. But my daughter knows the good things that are coming when she has her card and is able to go.
Absolutely. The golden ticket, as we call it, right? All right. So one last question that I am actually seeing kind of is speaking to the effectiveness of our testing. So someone is wanting to know, or they're concerned that the PCR testing that we have for our COVID test may not be as accurate as it may have been alluded to. And so could you guys speak on for one, the differences between a rapid test and the PCR, and then which one you feel like is the most effective, if they both are, just kind of all of that. Because I think there's confusion amongst a lot of individuals in the community when they're saying, okay, I need to get a COVID test, and then they may go get a rapid test. And then you may have employers or other organizations saying, hey, that rapid test isn't accurate enough for us. We need the PCR, which is like that next step. But then other individuals are saying that they don't really trust the results of the PCR. So could you both speak to that?
I've seen some of that, and I've seen it in folks so you have a rapid test and you have the PCR test. The PCR test takes longer. The PCR test is more accurate overall. The rapid test is good if you have COVID. If you have a positive test on the rapid test, you definitely have COVID. Like, there's no questions. You got COVID, there's no need to move forward. If you have a negative rapid test, you could still have COVID, because the false negative, meaning you have COVID and the test is negative, is up to 40%. That's why employers and schools say, we don't want that rapid test, because you're going to come in here with COVID and say, well, I had a negative rapid test. The PCR test, if it's negative, you're negative. That's good. Now, you have that incubation period. You may have to repeat that in 5 days, but the PCR test is better than the rapid test. If you have a positive rapid test, you definitely have COVID. If you have a negative rapid test, getting the PCR test will ensure that your rapid test is actually right, because it can be wrong 40% of the time.
Right. And I just want to add to that. The general rule is, if you are symptomatic and you go to get a rapid test and it's negative, then you absolutely need to get the PCR test to follow up. And then you can have a positive PCR test. And that may be a point of confusion where people don't understand why one test is negative and then the other is positive. And as Dr. Bowe just mentioned, the PCR is more accurate. So if you have symptoms and your antigen test is negative, then you're definitely going to need to get that PCR just to be sure.
Awesome. Thank you so much for that. I think we have another question. So it says, many people say that the, pronounce this word for me, REMIDSIVIR. I don't want to mispronounce it, but
Okay,
this,
we're going to
go
give the video.
all right.
The monoclonal antibody. They're talking about the antibody treatment.
There we go. Antibody treatment. Awesome. So many people say that this drug is what's killing people who are being treated for COVID in hospitals and or causing a lot of the long haul conditions. Could you maybe speak to this statement?
Yeah, that's not true. So monoclonal antibody treatment is under emergency use. It has been very helpful in some people in reducing the duration of symptoms and in reducing how long they're sick. It doesn't work in everybody. But once you're getting that antibody therapy, you already have COVID. The COVID is what's killing people at that point, or it's not. We use the monoclonal antibody therapy to try to help patients and keep patients alive. The problem is nothing is as effective as the vaccine. That's why we push the vaccine first. But if you do get COVID, we're going to try to help you in any way possible. So we will give you monoclonal antibody therapy. It's really either give you the antibody therapy or nothing. And when people are sick and dying in healthcare, we're not going to do nothing. We're going to do what we can. So it's not the therapy that's killing them, it's the disease. Now, we may not beat the disease. We don't beat COVID a lot of times in the hospital. We're still trying, but we don't beat it. But it's not the treatment, it's the disease. And if you don't want to have to worry about needing antibody therapy, you can get the vaccine and then you'll be better.
Absolutely. And then some people are too sick. They're too ill, too advanced to even get the monoclonal antibody therapy. So just remember, there's still some parameters around who still qualifies for it.
And I would say, just based on the numbers, there's a lot of people who have died of COVID who never got antibody therapy. So the data doesn't support that either. The science doesn't support it and the data doesn't either. We literally, in monoclonal antibody therapy, we're giving you antibodies to help you fight. Sometimes those antibodies aren't enough.
Right. And so, yeah, I can see where there might be a confusion where someone's thinking, well, they got it and they still passed away. Is it leading to the death? Well, no, like you guys said, they might have been too sick. It might have been, like we'd like to say, too far gone in this scenario to where they weren't able to actually benefit.
Well, I liken this to folks who are like, CPR is killing folks. You know, a lot of times they do CPR and that person still dies. Well, no, the CPR is not, it's a treatment for people who are ill, meaning you could still die, but it's not the CPR that's killing them.
Right. That's a great analogy to help people understand that. Awesome. Well, you know what, ladies, we have made it to the end of our town hall event. I thank you both so very much for giving us a wealth of knowledge. I really didn't even think we were going to get through all of our questions, but we did. So I am just kudos to the both of you for being able to do that. And again, we thank you all for joining us and we hope that you have a great evening. Good night, everybody.
Good night. Thank you.